Okay, good morning. Let's go ahead and get started. I'm Habib Samadi from Emory University, and I'll let my co-moderators introduce themselves and we'll get going.
Good morning. Thanks for joining us. I'm Bill Furon from Stanford, California.
Good morning. I'm Alan Jeremiah from Stony Brook University on Long Island.
We thank the program organizers for helping us put together this great session. The title of our session is Maximizing PCI Outcomes, and we're going to look at lesion assessment by FFR, IVUS, OCT, and near-infrared. And to kick the morning session off, who other than Dr. John Hodgson, who's one of the leaders in intravascular imaging in IVUS. And John is going to talk to us this morning about what is the evidence that IVUS can help me perform PCI better. John?
Thanks. It's a pleasure to be here, and for all of those of you who got up early this morning, thank you for coming. These are my disclosures. I've been involved in this field since the mid-'80s, and actually did our first coronary IVUS 24 years ago. So it's been almost a quarter of a century now, and I want to try to share in the next few minutes what that 24 years of experience has taught us. And there's actually quite a bit of data now that suggests that IVUS can help us doing intervention. And I want to focus on just a couple of things here. Left main evaluation, the influence of calcium, which is critically important, some of the unique guidance capabilities that IVUS has, and then finish up with some of the routine stenting data that now shows both mortality and stent thrombosis benefit. So left main, obviously a very important spot for us. I think you're all aware that the angiographic assessment is unreliable, and you see two angiograms here that have similar looking distal left mains, one being very physiologically significant with a low FFR and the other not being. And you've all seen these kinds of pictures, and you will in the next talks as well, that even two experienced reviewers can't tell what's significant, what's not significant when you use FFR as a discriminator. Now, we have used IVUS, of course, to look at the left main as well, and this very nice study by Jasty showed that roughly a minimal lumen area in the left main of 6 square millimeters is the best predictor for a low or significant FFR. So 6 square millimeters is what we have generally used in the left main, and you can use this very easily in routine cases. So here's a questionable left main, ostial LAD, looks different in different views. This is not a case, as Mort says, to take 100 more views.